Welcome to Cambridge Forum, discussing Medicine in Translation, Healthcare Reform at the Edge. I'm Pat Zerke, director of the Cambridge Forum. Rhetoric in the current debates over reforming the U.S. healthcare system has grown increasingly heated as legislators try to balance access and affordability. In an ideal world, everyone would have health care. The realities of paying for that care, however, lead policymakers to find ways to limit universal access. And it is often the most vulnerable groups, the unemployed, the very poor, immigrants, that are left out. How can doctors reconcile their ethical and humanitarian responsibilities to care for those patients at society's edges with the limitations of our healthcare system? What kind of healthcare reform would make an actual difference in the lives of the most vulnerable and in the lives of their doctors? Danielle Ofri is an attending physician at Bellevue Hospital in New York City, where she has practiced for the past 15 years. She is also a writer, documenting her experiences as a physician at the world's oldest public hospital. The co-founder and editor-in-chief of the Bellevue Literary Review, she has published widely in both professional and popular journals, including the New England Journal of Medicine, Lancet, the New York Times, and the Los Angeles Times. Her previous books are Singular Intimacies and Incidental Findings. Her latest book, Medicine in Translation, Journeys with My Patients, serves as a starting point for our discussion. Amy Whitcomb-Slemmer is the executive director of Healthcare for All, a statewide advocacy organization focused on creating an affordable, accessible, culturally competent healthcare system. An attorney by training, she has worked on health policy for more than 20 years, serving as executive officer of the American Red Cross Biomedical Services and as legislative counsel for the National Association of People with AIDS. Ms. Lemmer began her career as a member of Senator Edward Kennedy's healthcare policy staff. We'll start this evening. Welcome to Cambridge Forum, Danielle Ofri.
Good evening, and thank you so much. Generally, when we give grand rounds at a medical center, we start with a case. So I thought I'd start with a case. Although in this case, it's really a journey that I've taken with one of my patients for a very long time. So long it actually starts back in a previous book of mine. And this essay initially appeared in the New England Journal of Medicine. But as I'm in denial about my need for reading glasses, I'm going to read from the book because the font is larger. And the chapter is called Torment. I groan when I catch sight of her name on the patient roster, Nazma Uddin, not again. I dread her visits, and today is no exception. A small, plump woman, Mrs. Uddin is cloaked in robe, headscarf, and veil, all opaque blue polyester. Only her eyes peer out from the sea of dark blue. She is trailed as usual by her 11-year-old daughter, Azina, who wears a light green gown with a light flowered headscarf. Mrs. Uddin flops into the chair next to me, and Azina perches on the exam table, with her white Nikes peeking out from under her floor-length gown. Mrs. Uddin unsnaps her veil, something she only does with her female doctor, and the litany begins. "Oh, doctor," she says, pinching the sides of her head with skin-paling force, "the pain is no good." After this brief foray into English, she slips into Bengali, aiming her barrage of complaints at Azina, who translates them to me in fits and spurts while fiddling with her wire-rimmed glasses. There's abdominal pain and headache, diarrhea and insomnia, back pain and aching arches, a rash and gas pains, itchy ears and a cough, and no appetite. The smothering sensation begins. If she doesn't stop, I will drown in her complaints. I know that I should be focused on Mrs. Uddin's words, but I fear for my sanity. I scan the computer while she moans about her shins and her coccyx, and I see that she's been to a neurology clinic, rehab clinic, pain management clinic, gynecology clinic, all in the 5 weeks since I last saw her. "Doctor," she's pleading with me now, again in English, and I hardly refocus on her. Why so much pain? The leathery grain of Mrs. Uddin's skin and her seemingly permanent submission in the world of the sick make me think of her as elderly. I am always shocked when the computer reminds me that she's only 35. Why, doctor, why? Her laments are punctuated by the resonant thud of Azina's sneakers, banging repetitively and absent-mindedly against the metal exam table. The truth is, I can't do anything for Mrs. Uddin. I've talked to her endlessly about stress and depression, which I'm sure underlie many of her complaints, but she never follows through with the psychiatry referrals or the antidepressant medications. Her resistance to my efforts sometimes makes me feel as though she's in a personal battle against me. I hate to see her in the waiting room. I hate the whine in her voice that is detectable even when she is speaking Bengali. I hate the veil that she wears. Any last bit of cultural sensitivity I possess is washed away. How can she let herself be hidden away in a sea of horrid polyester? How can she buy into that culture? I hate that she routinely keeps her daughter out of school to facilitate her wild overuse of the medical system. Whenever I treat one complaint, another bursts to the surface. An antacid temporarily relieves her stomach pains, but then she'll have palpitations and hiccups. I can't breathe, she says. I don't eat. I don't sleep. Well, if that's truly the case, I want to retort, how is it that you are still alive? I shudder as I realize that I am slipping too far. The annoyance and resentment are getting the better of me, but sometimes I wish she would just disappear, out of my office, out of my hospital, out of the city, off this planet. How is it that she emigrated thousands of miles from her obscure village in Bangladesh to end up precisely in the catchment area of my clinic and then randomly in my office? You are healthy, I say to Mrs. Udine sternly. No reaction. I turn to the daughter. Tell your mother she is healthy. All her tests are normal. Azina's face is blank as she translates. After speaking, the daughter looks down her sneakers, her light veil tumbling over her shoulders as she lowers her gaze. Are you almost finished, she asks. She looks up at me. I have to take her home on the bus, then I have to take another bus to school. I don't want to miss the whole day. Can't your mother come to the clinic by herself, I ask? We do have interpreters available. My mother's afraid to go out by herself, Azina says in a voice that wants to be belligerent but is too weary. My brother is in college and my father works, so I have to take her to the doctor. She stares back down at her sneakers, which have stopped banging and are now wriggling from side to side like lively caterpillars. I turn from the computer and really look at Azina. Her eyes are smooth sandalwood, magnified into iridescent discs by her thick lenses. What is it like at home, I ask. She doesn't do anything, Azina mumbles. She just sits there. Azina's face has a prepubescent chubbiness that is somehow incongruous with the seriousness of her headscarf and glasses. Tears begin to slide down her cheeks and her voice rises in a warble. She doesn't say anything to us. She doesn't cook dinner anymore. She doesn't go anywhere. My mind begins to paint a picture of the Udine home, and I see a little girl cut off from her mother, reeling in the wretched vacuum that depression creates. A child conscripted to be the fulcrum of cultures, illnesses, and torments, all while completing the 5th grade. I am mortified now that I was so consumed with my own feelings of being overwhelmed when before me sits a child who was drowning, a child grasping the rickety timbers that can barely support her mother and that threaten to sink them both. It is the innocence of this pain, its simplicity, that both shocks me back to reality and humbles me. I realize that never in all my visits with Mrs. Udine have I paid any attention to Azina. She was always a mere appendage to her mother's appointments, trailing along, obediently translating and directing as so many first-generation children do. Though I'd like to write off Mrs. Udine as just another complainer, as one who can't hiccup without demanding an MRI, she is truly suffering. Her daughter is truly suffering. I am not suffering. I am actually the complainer. I am the one who can't face this patient without immediately rolling my eyes and turning off my compassion. The reality is that I am profoundly discomfited by my inability to treat Mrs. Udine. I take the hands of both Azina and her mother, for they are both my patients now. Depression is a painful illness, I say. Broken souls can hurt as much as broken bones. I explain about antidepressant medications and the importance of psychotherapy, and we negotiate a contract for treatment. This time I include a stipulation that Mrs. Udine must come alone or with her husband. Azina must stay in school. Azina wipes her tears. Mrs. Udine gathers her papers and snaps back on her veil. She promises to take the medications and see the psychiatrist. Of course, we've been down this road many times before, and I won't be surprised if she's back next month with a new physical ailment, not taking her medications and having missed the psychiatrist appointment. And I won't be surprised if I, again, dread the visit. But I think, or at least I hope, that I'll no longer view Nazma Udine as a personal torment. Azina has cured me of that. This is when I first met Mrs. Udine quite a number of years ago, and she's been my patient for quite some time, and I see her quite regularly. Nazma Udine was back on my list for an appointment for the morning clinic session, weeks earlier than her scheduled appointment, but I was not surprised. When I called her in from the waiting room, she came down the hall accompanied by a slender young woman cloaked entirely in black. A black headscarf covered her forehead, resting just above her eyebrows, and a thick black veil came up over the bridge of her nose, leaving the barest slit for her kohl-lined eyes, an even smaller space than in Mrs. Udin's loose veil, which at least allowed her forehead to be exposed. The young woman's hands were encased in black linen gloves, and she moved like an apparition, with barely a rustle of her black robes. There was something both exotic and forbidding about her. I ushered the women in. As usual, Mrs. Udin unsnapped her veil, but the woman shrouded in black did not. I wondered if she was a relative visiting from Bangladesh. "Good morning," I said. Mrs. Udin's face was scrunched with frustration. She took out the bottle of antidepressants I'd prescribed at the last visit and plopped it on my desk. "These pills no good. They make veins in my neck swell. Fire burning in my head, no good." "For how long did you take the pills?" I asked. Mrs. Udin waved away my question like she was swatting a fly. "I take few days, but no good. I need better pills." If nothing else, Nazma Udin offered predictability. Every visit was consistent. We tussled gently over the same issues, negotiated compromises that we'd tried before, and gave the whole thing another go. We'd been doing this for 8 years now. I imagined us aging together, each offering the other a strand of stability. "How are things at home?" I asked. "Home good," Mrs. Udin answered, the tautness in her face easing. She leaned toward the woman in black. "Azina visiting, so things good for this week." Azina? This was Azina? Chubby, bespectacled Azina was now a slim high school junior. At the mention of her name, Azina turned toward us. "Mom," she said, "stop making such a big deal." I could see her eyes roll within the tiny slit of her veil. "It's just a visit, come on." Azina was attending a Muslim boarding school in upstate New York and was home for vacation. She slouched in the chair, and the cuffs of her jeans peeked out from under the edge of her gown. "How was school?" I asked Azina, wondering about her transformation. "Boring," she replied. "No boys in the classes, and they don't allow color," she informed me. I was intrigued by the differences between Azina's veil and her mother's. Mrs. Udin's veil hung loosely over her face like a curtain and unsnapped with ease. Azina's was a black cloth pulled so tight that I could make out the contours of her nose, cheeks, and lips. It was tied somewhere in the back under layers of her headscarf and gown. It looked vastly more uncomfortable to me, like it was smothering. She didn't remove her veil with me, and I wondered if that was because she'd become more religious than her mother, perhaps as a result of her boarding school experience. As I contemplated this, I realized how little I actually knew about the Muslim veil. Perhaps it was time for me to learn. I wasn't sure how sensitive a subject the veil was and wondered if it would be considered an affront to broach the subject. But I felt that I knew Mrs. Udin, and by extension Azina, well enough by now, so I asked somewhat timidly if I could pose a question about the veil. They both nodded. I asked Azina if not taking off the veil in my office like her mother was a sign of increased religiosity. Azina laughed uproariously as soon as the question left my mouth. "No," she said. "The only reason I don't take it off here is because it takes forever to retie and I'm just too lazy. Ask my mom." Her ease with this, along with the magnitude of difference between my assumptions and her reality, relaxed the conversational berth. I felt comfortable now and asked all sorts of questions about the veil, even naive ones. Azina took the lead in answering, her infectious energy spilling out despite the tight veil that completely wrapped her face. I wanted to know if it was hot under there. Was it hard to breathe? How did you decide which color, what style? Was it a family norm or a mosque norm? Did it differ in different countries? Azina and her mother chatted amiably, seeming delighted to educate me in this nuance of Muslim culture. While the subject had been a little touchy for me, it certainly wasn't for them. Taking a bit of a risk and pressing further, I asked if there was any pressure or coercion about wearing the veil. Mrs. Udin answered this one emphatically. "No, veil is my choice. My husband, he tell me not to wear it. He say people treat me bad. They say I am terrorist." Her voice grew more animated and assured. "But veil is between me and Allah," she said, pointing upward. "I wear a veil no matter what anyone say. It is my connection to Allah." The conversation proceeded toward Islam in general, and I learned how devout Mrs. Udin was and what pleasure religious observance gave her. The most interesting thing for me, beside all that I was learning, was the transformation that occurred in Mrs. Udin. While discussing Islam and the veil, she became buoyant. All her whininess disappeared. The aches and pains seemed to evaporate. Her voice and body language reclaimed the heft and vitality one would expect from an otherwise healthy 43-year-old woman. This was not a meek, oppressed woman, I thought. This was not a woman beaten down by a patriarchal religion. This was a woman inspired and fortified, dare I say, empowered by her religion. As I finished up my visit with Mrs. Udine, I realized that we just gained a new clinical insight, perhaps even a new therapeutic tool. I realized that I might finally look forward to Mrs. Udine's clinic visits. Although I didn't want her to keep Azina out of school for her appointments, I hoped she would come to some of them, so we could continue my education as well as her mother's treatment. The last part that I'll read, it's a short last part, happened actually quite recently. Nazma Udine was on the schedule for an appointment, but Azina, now a freshman in community college in Queens, showed up instead. Mrs. Udine wasn't feeling well and sent her daughter to pick up her prescriptions. The elevators were packed, so Azina had sprinted up the 3 flights of stairs in order to be on time. She was breathless when she arrived, skin flushed, cheeks puffing from exertion, upper lip peaked with moisture. Her hair was coming undone from its ponytail. It was only when she used the back of her hand to wipe off the sweat that it occurred to me what was different. There was no veil, no headscarf. The thick strands of her dark hair were glistening even under the harsh fluorescent lights. She wore jeans and a sweater. No gown covered her clothes. "I'm sorry my mom can't make it," she said, taking quick breaths between words. "She promises not to miss the next appointment." She pulled a clutch of refill slips out of her bag. "These are the prescriptions that she needs." "Azina," I said, my mouth hanging open, what happened to—" Then I stopped, unsure if I was treading on territory that might be too personal. Had Azina embarked on a college rebellion? Was there a falling out with her family? Did she find a boyfriend who was less religious? Was she making a statement about assimilation? But then I recalled how forthrightly and warmly Azina had spoken to me about the veil the last time, so I decided to ask, "Azina, what happened to your veil?" Azina laid the papers on my desk and smoothed them carefully. I had an incident 3 days ago." "An incident?" I said. "What do you mean?" "I was waiting for the bus on my way to school, and there was this guy at the bus stop." Azina looked past me as she spoke, directing her words toward the wall. He was looking at me funny. Then he started to talk to me. "9/11 was your fault," he said. "You killed 3,000 Americans." So I said to him, "I'm Bangladeshi. Bangladesh didn't have anything to do with 9/11. Then he started to walk over me in this threatening way, saying over and over, "It was your fault. 9/11 was your fault." I backed up against the wall of the bus shelter, and then he pulled out a knife and waved it in my face. "You people ruined our country," he yelled. I couldn't move. He had me pinned against the wall. Then he reached over with the knife and tore my veil and headscarf off with it. I was so scared he was going to stab me. The only thing I remember was that the pins that held it in the back scratched my neck as the veil came off. I must have screamed. I don't even remember. Some teenagers passing by jumped on him and pulled him off me. Azina's voice sounded wooden as she spoke, but to me, it was a sledgehammer in the chest. "Someone called the cops," she continued, "and they came pretty quickly. But I felt so naked, so exposed in front of all these strangers, so embarrassed that I was the cause of all this. The police brought me home, but I wouldn't leave the house for 2 whole days. Today's the first day I've gone out. My father told me to stop wearing the veil, that it was too dangerous." I looked up at Azina, her somber demeanor a punishing contrast to the voluble, engaging teenager who'd spoken to me last time. I reached over and touched her sleeve. "Azina, I'm so sorry this happened. This shouldn't—" "It's okay," she said, cutting me off. "It's not anyone's fault. There are stupid people everywhere, and he was just a stupid guy." "But still," I said, "this is horrible." "I'm getting over it," she said, the color returning to her voice. "I've decided that I will probably wear my headscarf, but maybe not the veil. My father is against it, but this is America, and I can do what I want. Besides, I can't sit around feeling sorry for myself. I need my energy to finish pharmacy school and to take care of my mother." She rolled her eyes dramatically, "and you know how much TLC my mother needs." Thank you.
Now let's hear from Amy Whitcomb-Slimmer of Healthcare for All. Amy, how could the people that Danielle cares for be helped by the current proposals for healthcare reform?
Oh my goodness, thank you so much. It's a pleasure to be with you this evening. And I guess I have a very quick answer, and that is we need to make sure everyone has access to somebody as wonderful as Dr. Ofri. That's a remarkable story. And one of the things that Healthcare for All is challenged with is raising up awareness about the difference that a culturally competent provider has when interacting with their patient. So I think you've just heard from Danielle a transition that happened because she spent a significant amount of time listening to, persevering through difficult visit after visit before getting to the root of some of the problems that Ms. Udine was having. So that was remarkable and very powerful, and I appreciate that very much. I know that most of you in this room are very aware of the fact that we find ourselves at an unprecedented moment in the history of health reform in this country. As you heard at the beginning of my introduction, I began my professional career as a member of Senator Kennedy's health policy staff. And it was there that I learned at the hand of a master about the importance of cultural competence and making sure that when we talk about healthcare for all, we mean everyone. And it is my privilege to continue his life's work as the Executive Director of Healthcare for All. And at this moment, when we are at the precipice of reforming our national healthcare system, I think having this opportunity to talk about some of the folks who are marginalized and often hardest to treat and reach in our country is a remarkable opportunity. So I welcome this opportunity to talk a little bit about where we are and what national reform actually holds in store for some of the people that Dr. Ofri treats and sees. First of all, contrary to popular belief, the entire world has not changed with the election of one senator in the great state of Massachusetts. We have elected a new senator for the great state of Massachusetts. I do not believe we have derailed the movement for national health reform, as I believe, I'm happy to applaud that. I feel very strongly that the politics may have changed. We've gone from a supermajority in the Senate to a really good majority in the Senate. But the principles have not changed. We continue to have 40 million uninsured people in this country who are waiting to have access to life-saving health care. And as many of you may know, some of the most remarkable parts of national reform that we're talking about are built on the experience that we had here in Massachusetts. In Massachusetts, we have the privilege of being able to talk about the fact that we have the lowest uninsured rate in the country. And at Healthcare for All, what that means is we hear from thousands of people across the Commonwealth who call to tell us what a difference it's made to have access to the healthcare system in their lives. Folks who had never had access or gone to a doctor or provider before have shown up and found that, in fact, they need treatment and are able to receive the treatment that saves their lives. Or others who were discriminated against based on pre-existing conditions, who now are able to have a relationship with a provider and are able to manage a host of problems and maintain good health and live healthier and more productive lives because of health reform in Massachusetts. So I'm going to talk a little bit about the provisions in national reform, and then some about some of the direct benefits that we have in Massachusetts, and then finish with a charge for action, and then happy to have questions. In both first of all, let's all remember, Congress has voted for health reform. Both chambers have voted in favor of national health reform. And now we need to figure out the next steps to get it to the president's desk. In both the House and Senate versions, both bills contain something called the Community Living Assistance and Services Supports Program. This is a program authored by Senator Kennedy to provide a benefit for people with disabilities to help them live independent lives. And as I say, because it's in both bills, we feel very confident that this will be part of national reform that passes. All consumers will benefit from national health reform because of something called consumer engagement. Another element that is based on the work that we've done here in Massachusetts. We know that if you suddenly have a requirement to become insured, or you insure tens of thousands and hopefully millions of people, there is a huge shift that needs to take place so that people like the patients in Dr. Ofri's book need to have access to information about how to take advantage of the insurance. How do you pick a provider? How do you access the services that you now are eligible for? And Healthcare for All has pioneered a helpline. We have an 800 number that people from all across the Commonwealth call. In tens of thousands of calls are fielded each year, and the counselors at Healthcare for All connect people to the care they qualify for. So we help students figure out what they're eligible for. We help newly uninsured people, new people to the Commonwealth, people who have been disenrolled from their insurance for whatever reason, connect to the services and the benefits to which they're entitled. And it's not just a one-way street. It's the reason it's referred to as consumer engagement at the national level is because this is a two-way street. These helplines not only provide a direct service to people who need them and are trying to navigate a fairly complicated system, but it also is an opportunity to aggregate the information that we're hearing to improve the system we're working with. So at Healthcare for All, we feed back the information we get from our callers to the state so that Massachusetts can improve the health reform bill and implementation process in direct response to the callers who talk to Healthcare for All. One of the things that we feel most strongly about, and I appreciate the mission statement for Healthcare for All being read, because we truly are advocating for comprehensive, affordable, culturally competent healthcare for everyone, including and especially we call out the most vulnerable among us. And one of the things we know is needed for vulnerable populations is culturally competent care. And we also know that you need to pay special attention and provide incentives for people to go into the healthcare system so that we better reflect the communities that they're trying to serve. Imagine what it would be like for Dr. Ofri's patient if there was a Bangladeshi doctor on staff who could jump in and provide direct experience and a relationship based on common cultural factors. I believe you made amazing inroads and a relationship and a connection with the family, but wouldn't it be wonderful, and it sounds like the daughter is going to become a member of the healthcare system, which is marvelous, and another testament to your good work, I'm sure. But we are pushing hard to have workforce diversity initiatives included in national reform, and there are some very impressive provisions in the Senate bill. And in Massachusetts, there are some incredibly innovative programs going on. Recently, UMass talked about a marvelous program to reach into high schools, identify high school students who would otherwise be at risk in poor neighborhoods, and connecting them to the med school so that they will be mentored through high school, through college, and will have med school scholarships, which is very exciting. I've just learned about a program that has decided, in fact, high school may be too late to attract healthcare providers. They are mentoring and becoming pen pals with second graders. So these second graders at this giant Boston-based hospital system receive notes and encouragement from professionals on staff at the hospital and come in twice a year. And the hope is that they'll feel some sense of connection and comfort in a healthcare system that is often foreign and used as an emergency basis without kind of appreciation and use for primary or preventive care. The national legislation that is in front of us makes some true investments in loan forgiveness programs, in reaching into communities to attract providers who will better or be able to represent their communities. The other thing that we at Healthcare for All are working very hard on is having an amendment included in national reform that will lift the 5-year bar for legal immigrants to this country. So right now, there's this arbitrary requirement that you must be here legally for 5 years before you can access any of our public benefits in the country. And in Massachusetts, I'm very proud to say that when we passed healthcare reform in 2006, we extended that offer, healthcare reform, to all residents of the Commonwealth, regardless of your birth origin. But if you were here legally, you had access to healthcare services. And we think it's vitally important that the national work reflect the fact that if you're here and you're contributing, you deserve the right to have access to healthcare coverage, life-saving healthcare coverage. And we're motivated at Healthcare for All by some of the statistics that we've read about the death rates that happen for people who don't have healthcare coverage. There are 40,000 people a year die needlessly because they didn't have access to our healthcare system. In Massachusetts, we're incredibly lucky that that number is significantly lower because we have so many folks who are covered. But it's a waste. It is a missed opportunity for these people to contribute to our society, and imagine the devastation that they leave in their wake. We believe firmly that this has to be stopped, that we must pass national health reform so that we can bring all people into the healthcare system. As I say, for us, Healthcare for All truly means everyone. There are some stories that we've collected at the helpline from people who can point to the fact that they now have access to life-saving medication, that they have relationships with providers, that having access to healthcare coverage has literally saved their lives. And in Massachusetts, we made a strategic decision to work on healthcare coverage first. And I will say that Healthcare for All was a little reticent, and we had some concerns about the bill that was pending in 2006. We wanted more generous benefits. We thought there were opportunities to go after quality improvement. We very much wanted to talk about cost. However, we got to the point of passage of the bill, and I invite you to think about the current environment, and decided that as a consumer advocacy organization, as the organization dedicated to getting healthcare coverage for everyone in Massachusetts, we would work within the compromise and support the bill that finally passed in 2006. And I will say that I know there were lots of internal discussions, and I know that as we talk about in Massachusetts shared responsibility, that business was having some of the same qualms, and the state government was trying to figure out if they could truly provide the subsidies that were going to be required. However, the interests aligned, and we were able to pass reform. And I know, as I say, what a tremendous difference this has made to individuals in Massachusetts. Now, we are 3 years beyond that. We get to talk about having the lowest uninsured rate in the country. We have covered 400,000 people in Massachusetts since we passed reform in 2006. And now we have the opportunity to work on phase 2 of health reform. So in Massachusetts, we're now working on quality and cost. We're talking about thinking about ways to improve the quality of the health care that's delivered to us and reducing the cost to individuals, to the system, that health care, that our current coverage demands. I believe there were an awful lot of people who went to the polls and supported Senator-elect Scott Brown because healthcare coverage is taking up more and more of our budgets. I know that for Healthcare for All, my health insurance costs for my organization went up, and it's very difficult when, in fact, our fundraising didn't necessarily keep pace with our healthcare cost increases, and I believe that's reflected in individual family budgets all over the Commonwealth. However, we have an opportunity to talk about the next phase of health reform, and as I say, for us, that is in the realm of payment reform. Healthcare for All is working using recommendations that were put out by the Payment Reform Commission over the summer to look toward a time when we move past and beyond fee-for-service healthcare. We know that that studies show, and I believe intuitively, we can probably appreciate the fact that a fee-for-service system often rewards the quantity of services we receive without necessarily rewarding the quality of the services we receive. So our providers, the more tests that are done, the more times we're seen, the more money our provider receives. However, if she keeps us well, if she puts us on the right path, as Dr. Ofri clearly has been able to do in a visit and make sure we're connected to the services we need, there's no ancillary benefit for the provider. We think it's really important to think about a different payment system so that we can discuss our comprehensive health profile so that we can work toward wellness instead of working on our sick profile. And we think this is a very exciting opportunity. Again, if you look at the national stage, we are once again at the cutting edge and about 5 years ahead of where I think an awful lot of people in Washington find themselves. However, in national reform, there are some very exciting pilot projects that are included in legislation that would allow some of these pilots to begin across the country. So we're very encouraged about that. And for people who are not sure about national health reform and how it fits in or would benefit Massachusetts, I would remind us that there are a whole lot of benefits that would come to the Commonwealth, even though we have taken the steps to cover our folks, even though we have some of the finest healthcare in the world at our disposal here in Massachusetts. There are still things that we feel strongly will be of benefit to the consumers in this state, including increased subsidies for people who make up to 400% of the federal poverty level. One of the compromises that had to be made in Massachusetts in 2006 was that we could only provide subsidies for people making up to 300% of the federal poverty level. So right now, for a family of 4, that's about $66,000 a year. If you make above $66,000 a year, you don't qualify for state-based subsidies for your health care coverage. In the federal bill, that would increase to 400%, so that a family of 4 making up to $88,000 a year under current numbers would be eligible for subsidies. And we think that's vitally important. We know that there is this struggling sector of folks who want to buy coverage, who want to have access to health care, however, really struggle with family budgets and the cost of health care. We know that this will make a tremendous difference. We also know that there are some tax exemptions for small businesses. You've heard an awful lot, and I think it is vitally important that we pay attention to the fact that employers in Massachusetts, one of the scare tactics we heard in 2006 was that employers would drop coverage. If you have better state-based programs, if you have more wide availability, there would be crowd out and employers would no longer provide coverage. And in fact, to the credit of the employers in Massachusetts, that hasn't been the case at all. There are now more employers that provide their employees coverage than there were before health reform. And we have an exchange. As you listen to the national debate and you hear people talking about whether there should be exchanges or not exchanges, here in Massachusetts, our exchange is called the Connector. And our Connector actually has some power to negotiate with healthcare insurers to lower the costs of plans that are provided. And we've seen a significant decrease for the people who have bought these plans for individuals and the small market, which has made a big difference. And again, in national reform, there'll be increased subsidies and tax incentives for small businesses to make healthcare coverage more affordable. There are also grants for medical research and innovation, and we know this is incredibly important, and Massachusetts is poised. I don't know of any other jurisdiction that is more ready to take advantage of these grants and subsidies than Massachusetts. There will be money for innovation, not unlike the stimulus money that's being spent and invested with alacrity around the state. There will also be grants available for research and innovation. And finally, the Medicare donut hole will be closed almost immediately, so that seniors will see a decrease in their drug coverage costs immediately, and we think that's vitally important. So from a macro perspective, I have some concerns, and those concerns have to do with timing. I think the longer we go on not having passed reform, the more people get worried and back away from the edge of making a significant difference for this country. And I worry about that. I think the interpretation of the Scott Brown election has been surprising in that one person might stop a debate that's been going on. You know, for those of us who've been working on this for decades, it is astonishing to me that we would back away from being on the precipice of doing marvelous things for millions of people in this country based on the election of Senator-elect Scott Brown. I will remind everyone, and I'm positive you all know this, that Senator-elect Brown supported health reform in 2006 in Massachusetts. He lives with constituents who can speak about the importance of this reform in their lives. And we hope that he'll be able to spend some time in Washington talking about the benefits of health reform in Massachusetts, and that is awaiting the rest of the country once health reform is passed. I think in Massachusetts, one of the things that we learned, and I would call on any legislators to pay attention to the fact that in this Commonwealth, we had almost instantaneous benefits to passing health reform. There were people within 4 months of the bill passage who suddenly had access to care. In national reform, I think it's vitally important to pay attention to what some of the instant benefits will be. I think in the Commonwealth, we take for granted sometimes the fact that we have had insurance reforms before we had health reform. So we are not discriminated against based on pre-existing conditions. Please hear the national debate and know that those reforms that are baked into the reform legislation are based on the work that we've done here in Massachusetts. So no denial of benefits based on pre-existing conditions, medical loss ratio that's limited, and importantly, a limit on the amount you're allowed to charge people based on age. I had no idea until I returned to Massachusetts that we were in the vanguard of limiting that amount to, I believe, the amount is a fairly modest increase, but I know around the country there are some folks who pay 3- and 4-fold what a young person does based on age, which is just wrong and will be taken care of with national reform. So, having run through scenarios and some of the benefits in Massachusetts, I want to say this as a charge, a call to action. We learned in Massachusetts that you will not get a perfect bill. Had we waited, there would be 400,000 people in Massachusetts who didn't have access to health care coverage. I believe now is the time, and I know from experience that we won't get this time again. So it is vitally important that those of you who are working on health reform, those of you who care about consumers, those of you who have been working for social justice for any part of your professional or volunteer career need to get in touch with the members of the House. And the House of Representatives has to pass the Senate bill and then make the changes and the adjustments that we care about during reconciliation. If they don't do it soon, I don't think we have another opportunity. I certainly don't see one. And as the President has said, we don't quit. So this will be a process of ongoing improvement, but the time is now. For the people you heard about in Dr. Ofri's book, for the people who are voiceless around the Commonwealth and around this country, for the people who are worrying about medical debt and choosing medicine over mortgage or mortgage over medicine, for the people who cannot sleep at night for fear that they will get sick and not be able to care for their children and not care for themselves, we absolutely have to pass national reform. So I invite you to join me in this effort. I believe it'll take all of us working hard. I know the Massachusetts delegation can play a leadership role in promoting this change, and I know it will make a huge difference for all of us. Thank you very much.
Okay, let me remind the radio audience that you're listening to Cambridge Forum as we discuss medicine in translation, healthcare reform at the edge, with Dr. Danielle Ofri and Amy Whitcomb-Slimmer of Healthcare for All. I'd like to start off the questions by asking Danielle Ofri. You talked about a case, you talked about patients, you talked your observations are very, very people-centered, and you were obviously able to find time and the ability to interact with Mrs. Udine and her daughter. Could you reflect on that experience in the context of the system that you work in at Bellevue Hospital and the demands on your time and the demands on billable hours or whatever they're called at Bellevue Hospital, and talk a little bit about how you bring that really human experience of being a doctor to be functioning within this healthcare system.
Thank you. One of the challenges in medicine is the tension between things that we measure as quality, and I'll put that in quotes, things we need to accomplish, various administrative requests, and then what it takes to really practice medicine. And I think they're often not the same thing and are often in conflict. There's this increasing trend toward quality measures, and in our hospital we get various reports on our blood pressure levels, cholesterol levels, A1C, and that's one aspect of healthcare. But when you are looking for a doctor for your child or for your parent or for yourself, and you ask someone to please recommend a good doctor, it's rarely where they graduated or their statistics on the web, but it's who the person is who is going to take care of you. Because I think that ultimately you're entrusting yourself with a physician or a nurse, and that's going to be the most important thing. And it's very hard to quantify. And so when I think about these rating systems, I get a little worried because I don't know if they measure what it is that when I think of who's a good doctor, who I take my family to, that I would measure. It's a real challenge. We have a 15-minute session, and patients may have 3 or 4 illnesses. They may have psychosocial issues, language barriers, economic barriers, that all have to come into play. We need to document everything. We may use an interpreter. It's hard to get that all done and address your patient's real needs. Often the agenda is not what they come in saying. They may say, I have chest pain, but in fact there's something else going on. And sometimes it's only when we shift away from the standard exam. The example that I use is now that computers are everywhere in our system, they're very efficient, they're great data collectors, but I find they actually compete with the connecting part between the doctor and the patient. In my clinic, in order to finish on time, I must write while I talk to a patient. It's impossible not to. So then I'm looking at my computer screen and not at my patient. And it's a very stilting experience. So I find that when I go to the exam table, when we're now touching, when we're not sitting with a computer, when there's a physical intimacy, it's not a romantic intimacy, but intimacy nonetheless, the dynamic changes. And often that's the time the patient can say what's really on their mind and when the trust is established. So it's a real challenge. So advice I give to my students who are often frustrated, how do you do this in 15 minutes? Simple things like for the first 2 minutes, I don't write anything down or don't look at the computer. It's a small amount of time, but it's very long in making a connection. Making sure to ask, did we get to everything? Is there something else on your mind? And then sometimes it's over time. With Mrs. Udine, it took many years. She's been my patient now for more than a decade. And like I said, I feel like we're an old married couple at this point. And often I don't get that luxury of continued care. But if there's that chance, and she keeps coming back, no matter what I do, she's always coming back. And so part of me never wants to leave Bellevue because I have patients like this who I've had for decades. So I think that you can have continuity of care. But I just worry that these measures of quality don't measure what I think is the real quality of compassion and healing. Yes, I want a doctor who's good, but you know what? Most doctors are good enough. I really do think they all graduated at the top of their class. They did okay. There's probably a few bad apples, but what really makes the doctor the person you want to entrust your life in are things that you can't quantify. And that's what I think most patients react to when they say, this is a good doctor.
I'd like to follow up. Some of the things you talked about relate to the concept of the patient as the consumer, and you've given at least a little bit of response to that idea. What kind of a consumer of medical services can a patient be? And Amy, I would like you also to talk about the idea of how can a patient, a sick person, or somebody looking for a doctor for their sick child or sick parent, how can that person be a consumer the way somebody going out and looking for a new television set or a car or a blender is a consumer? And is a healthcare reform effort based on the consumer's choice really going to cover all of the intangibles that Danielle Ofri has mentioned?
Well, I use consumer and patient interchangeably. I think it is vitally important as we look to improvements in our healthcare system to make those changes patient-centered. So imagine if you were a non-English speaker and your provider, you only have 15 minutes with him or her, And one of the things you have to get over is a language barrier and a cultural barrier. And you have all this time that needs to go into being put at ease before you can begin to discuss your intimate health details, and for whatever reason you happen to be there for the appointment. You know, we've heard stories on our helpline, and I should say at Healthcare for All, we work hard to be culturally competent and answer questions in English, Spanish, Portuguese, and Mandarin, and I always am looking for the opportunity to expand beyond that, because we know there are certainly communities we're not yet able to serve. But we hear stories about providers doing the best they can, but to try to get language translation services, pulling somebody off the janitorial staff or someone who has no medical training whatsoever to do some of this translation. And again, if you can think of how you would feel if a stranger were to come in and try to translate the information that you're trying to convey to your provider, it's simply a non-starter. So we believe that there must be incentives built into health reform that will attract culturally competent providers and will include training for all healthcare providers so that they understand some of the linguistic barriers, cultural barriers, and will allow people to break those down so that you can get to the underlying medical issue. And again, part of payment reform in Massachusetts is the opportunity to talk about not paying providers in 15-minute increments, but in fact being able to incentivize the ability to spend whatever amount of time it takes to be able to make some of the connections that Dr. Ofri was able to talk about with her patients.
So it sounds like you don't think that a patient is actually a consumer like the buyer of a television set.
That's correct.
Okay.
I
Just to
certainly-
be clear.
I'm
Yes, thank
intrigued
you.
by the choice of language. When I hear the term consumer, it just seems like the wrong word.
Agreed.
When I've been a patient, I don't feel like a consumer. I actually want to be a patient. I want to be taken care of, not being treated like I'm shopping for a television. I'm also, our hospital uses the term provider too, and I always think, am I working at Burger King? I'm a doctor, and I realize we're trying to be inclusive of all caregivers, but there are doctors and nurses, and I'm often called a hospitalist. I think, what a strange thing. Do I take care of hospitals? No, I'm a doctor, and my patients are my patients. In this setting, it's not a business transaction, and it's it's so different than shopping, because when a patient comes to us, they're very vulnerable, and it's very different than when you're shopping for something. You're not in that vulnerable position. You can be in a position of power. And even an educated, well-off person with many resources who comes in sick is in a vulnerable position. And I don't think people feel like consumers. Maybe when you're shopping for your healthcare plan, maybe you're a consumer, but when you're with your doctor, I think most people feel like patients, and there's something honorable about that, not that we should really give honor to and treat that vulnerable time, which is why the measures of quality that go into shopping for a TV aren't really the same when shopping for your doctor or your hospital. I don't think the statistics can really convey what that interaction is.
I'm curious, and then I'll open it up to the audience, so be thinking of your questions. I'm curious if you can imagine aspects of healthcare reform that would take this view of the patient, as a vulnerable individual who is in need of care and doesn't have all of the options available that the legislator sitting in his office writing the bill, or the lobbyist sitting in his office writing the bill might have at his disposal.
I can think of one. Whenever I finish a visit, I have to code in order for our hospital billers to bill. So what's fascinating about coding, there's all different levels of visits, and a lot of it is based on elements of the history and physical. And of course, it's very much procedural based. The more procedures you do, the more you bill. Well, internists, we don't do procedures, we talk. And it's very hard to bill for talking. Now, you can code that you've actually spoken for 20 minutes about medications, diabetes, but I learned that's a red flag. And if you code for that too much, talking with your patients, you'll be audited. So I thought that could be one place that shouldn't be the red flag. That should be the standard, that we do say we speak for 20 minutes. And that part can be considered as valuable as, sticking a tube in an orifice, because I think that's really that's the major part of medicine. We talk and we talk and we talk and we listen, and procedures are a very small part for your general primary care doctor. So that would be my solution.
Amy?
Well, I would say there are a couple of benefits baked in in national health reform, including one that I think is vitally important, and that is their incentives for primary care docs. I think it's a practice that we have not valued as much as perhaps other disciplines lately, and I think that there's an opportunity with national reform to attract more primary care providers in the state. In the states. There are some reimbursement improvements so that primary care providers will actually be paid slightly more under Medicare than they currently are, which again, I hope will make a big difference. But again, the idea that Dr. Ofri would have to worry about how to categorize what she's doing with the patient when in fact she's trying to spend that time talking about overall health is a real frustration, and I think we do have an opportunity to move beyond that so that if she in fact is talking about overall health and is able to avoid a second follow-up appointment for her patient, which is great for the patient not to have to leave work or find another way to get back to her, there should be some benefit to Dr. Ofri's good talents based on that success.
Okay, now let's take some questions from the audience, and I remind you to come forward and use the microphone here in the center aisle. And feel free to line up at the microphone.
I'm just wondering, the Massachusetts healthcare plans, I know there are several classified as Commonwealth care. I know you know what that is, as distinct from the Medicaid or the Mass Health. Do you find it difficult to get healthcare providers who will accept, say, the Commonwealth care or the Mass Health? Has that been a problem, or is it sort of a non-problem?
In fact, we've found that some of the disparities are based on geography, so that there is plenty of capacity in the state in some areas and then not in rural areas. And that's a challenge that is echoed across the country. But right now, I'm sure that there are examples of people being very frustrated with waiting times, but we've been very pleased with the number of providers who have opted to provide services to the populations who buy into Mass Health or ComCare.
Thank you for a stimulating discussion. Amy, you commented on documented immigrants and the services that they can access. Can you comment on the undocumented and what is available to them, if anything, and the decreasing funding for our safety net hospitals?
Well, it's a real challenge. The safety net in Massachusetts is losing money, and it is a provider reimbursement of absolute last resort. We know that in Massachusetts there are folks who are here, are undocumented, who wait until the absolute last minute to go and seek assistance, and therefore are at a more acute stage of need than they would otherwise be. And it's a real challenge for the system. We at Healthcare for All have been advocating very strongly on behalf of the 30,000 people who are here legally, have been here less than 5 years, and used to have access to the Commonwealth Care Program. They are, as a cohort, generally a younger and healthier population than the general Massachusetts population, but budget cuts were made last year, and those 30,000 folks who, in the parlance of our state legislature, are referred to as aliens with special status. So these special status immigrants were lost access to Commonwealth care and were given access to a new program that does not provide the same level of benefits and includes co-pays, and that's called the Commonwealth Care Bridge Program. So we're advocating as strongly as we possibly can to return this group of folks back into ComCare because it is wrong, we believe, to exclude them based on their place of birth and how long they've been in this country.
Danielle, if you have come back to the microphone so we can hear you.
Still commenting on the document, when you say they're legally here. So
Yes.
what's available for those who are undocumented?
There is emergency-based care. rule is you cannot turn people away. However, there's not access or the ability for people who are not documented to get primary or preventive care. So what we see is they become sick and wait until they have acute needs.
So there are no efforts at the moment for healthcare for all to get those folks preventive or primary care?
We answer the helpline. We know that people are referred to us so that we can connect them where we know they can get care, but right now there's no program available. And I wish there was political will to talk about all people in Massachusetts, but right now we are talking about folks who are here legally.
And Dr. Ofri, can you comment in your patient population in New York, if there are any services that are...
Our hospital is open to all, and a large percentage of our patients are undocumented. I don't know the number because I don't ask, but I know that many patients, they come in as self-pay, which means uninsured, and a majority of those are undocumented, though I do have a number of patients who are recently employed and then lost their jobs and lost their insurance, a new population. I think that a public hospital tends to be a refuge, and patients come, the generation of immigrants have always come to Bellevue, and even when the groups have moved on socioeconomically, often continue to come to Bellevue once they're employed and citizens, because it's a very warm and welcoming place, and it is quite multicultural. So all of our city hospitals are the places that our immigrants, whether documented or not, can get primary care. We're limited simply by whatever limitations we have for our services in general. The wait is long. The next available for Dr. Ofri is June 23rd right now. So when my patients call, I either have to overbook them or they have to wait until June to get an appointment with me. So that's a problem. And it's the reimbursement, mainly federal, that helps support the Health and Hospitals Corporation, which is New York's city hospital system, but we're in the red for sure.
There was recently the Front Page Globe story that talked about the gentleman who needed a heart transplant, was here was undocumented, was here, and was bounced. I believe when the Globe picks up, he was on at his third hospital. All of that incredibly acute care, and imagine the disruption to himself and his family, but also the extraordinary expense of the healthcare system, rather than allowing him to have access to care that may or may not have prevented that need, but would certainly have shortened the amount of emergency work that's going on for him. So I think it's incredibly important, and I also know that it's a challenge in Massachusetts. And I believe we'll begin to hear more and more about it as the budget numbers become harder and our policy options become more constrained by budget. So it's a real challenge, but vitally important. Healthcare for all means all.
I'd like to ask Danielle, we heard a little bit from Amy about how she is looking at the proposals for national healthcare reform. How are you as a doctor looking at them?
A little bit overwhelmed. Certainly those of us in New York look up at Massachusetts and with a little bit of a roll of our eyes, how could you guys do that to us? But I think we view the idea, if there's any way for more of our patients to get coverage, that will be better. And I realize that there are shortcomings in the Senate bill compared to the House bill that are significant. I think most practicing physicians are simply overwhelmed by the number of details, and that we just can't take it in anymore. We have a gut sense that it's probably good and probably better than nothing at all. But to be honest, most practicing clinicians just can't delve into the details, and we have to keep our nose to the grindstone just to stay afloat. I think for most, again, our patients who do have access to care with or without insurance, I mean, there are co-pays, but they're fee scaled, so most patients can be affordable, although not for all, that's true. There is a place to come to, but if you don't live near a public hospital, then it's a different situation. Then the issue of coverage becomes that life or death situation. We are lucky to live in New York City and have public hospitals, but some public hospitals have closed or have really consolidated. So I think my gut is that it's good, but I'm not sure. I'm nervous about some of these quality measures and quality mandates, things that I don't think really actually measure quality of care. They're easy to measure, but they don't actually capture the essence of good quality care. I hope that it will be a good thing. I'm keeping my fingers crossed.
Okay. Other questions?
I'm an adult and child psychiatrist, and in the late 80s, when managed care became an intense thing to deal with, I resigned from most of the panels. And at that point, made a moral and ethical decision that so I could see people who couldn't afford to come, I'd see them for free, or I'd have a portion of my practice that would be pro bono. So I just want to tell you an anecdote that happened recently. So I have nothing to do with insurance companies, but since my patients have insurance, and mainly I think this is for you, Amy, that if I write a script now, sometimes the pharmacy will call and say, sorry, doctor, but you need to get pre-authorization. Otherwise, your patient's going to pay $200 a month for this med instead of $5 a month for this med. Here's the number to call. So I call on the number, and I get a computer voice that says to me, what is your name? So I say my name. I have to identify my birthday, too, and as I'm getting older, I kind of wonder, should I say the truth or not? Then I have to say the patient and their ID number and their diagnosis. And then this computer voice said, this was 45 minutes of time, which is not billable. I won't bill anyone for that. The computer voice says, are you the authorized prescribing entity? And at the point that I decided I was not an entity, I said, human being. And they hung up on me. So 45 minutes later, to protect my patients, I decided I was an entity and said yes and got through the whole thing. But then I finally got through and called again to find, what they do also is they'll ask 3 questions, the general medical questions, not about the patient, not about the med, and possibly not in any way related to being a safety net in terms of making sure the prescription is correct or that there's no harm done. So I called and got a human being at the insurance company, and I said, why did you choose those 3 questions for this patient and this med? And they couldn't explain. So what I'm worried about is that, okay, the good news is these people are covered by insurance. Somebody else is going to help pay for the med they need. They're going to get the med. But there are these layers of people who are asking questions that they don't know anything about, and I'm sure they're collecting a salary. I'm being an entity. I'm not a human anymore. I'm so sad about that. But anyway, I'm worried about if that's what phase 2 is. So the plunk in of the insurance coverage, and that's great, but that includes this kind of extraneous stuff that isn't protecting anybody. I don't even know how to protest.
So my instant response is, good grief, as we're trying to squeeze costs out of the system, think of the waste that you just went through, in addition to how incredibly fortunate your patient is that you hung in there for all that time. I think it's vitally important that we get rid of some of the administrative layers that add no value whatsoever to, and in fact, as the case you've just pointed out, take away the time that you have to spend with your patients. So I'm with you. I think that's incredibly challenging, but I am hopeful that there's an opportunity to get rid of some of that just administrative waste and the hoops that you've had to jump through to be able to provide the best possible care for your patient.
What I was worried about is these 3 questions were kind of Atul Gawande's checklist manifesto, but kind of narrowed down and in a distortion, used in a distorted way. Or do you have power to do anything about this?
I'm certainly going to carry the anecdote with me. I will also say that Healthcare for All has been very excited about the checklist manifesto. However, not in that setting. We've talked about the success that folks have had in using them in the OR, and the number of mistakes and errors that have been eliminated based on the quick run through of these checklists. So we'll be talking quite a lot about that as a tool to improve quality. But I don't know about it as far as screening folks and determining whether or not they are appropriate for specific prescriptions. That's troubling.
Okay, and I applaud you. I mean, when I was with insurance companies, I could at least bill for 50 minutes to speak. And I can barely say hello in that amount of time, so.
I can just give the quick tale of 2 phone calls. When my first pregnancy, I needed to get Rogam, and I called my insurance company. I thought, this is a routine medication. And it took close to an hour of going around to get a standard medication. and but I finally got it. And then my dog lost her dog license, so I had to call the New York City Department of Veterinary Services. I thought, oh no, negotiating New York City's whatever. I called the phone. I pulled out my tax form. I thought I'd do my taxes while I'm on hold. And a person answered on the second ring and said, hello? Hello? I was so startled. I said, my dog lost her license. I said, oh, just put $1 in an envelope and mail it to us. We'll send it back to you. I said, $1? He said, yeah, just mail it to us. I said, okay, and I hung up the phone. And I was startled the difference of these two phone calls, that for my own health care, I had to spend an hour fighting a phone tree. For my dog, it took 2 seconds, and it cost me $1. So maybe we can learn from our pets.
Thank you for your story. Only if you like talking. That's all I can say, how are you?
I'm fine. Well, I have the feeling that there's a fly in the ointment. Or maybe it's the 600-pound gorilla in the room. And these metaphors I'm referring to are the political forces that have kept us from universal health care since Hillary Clinton started working on the project. Now, we know that this 600-pound gorilla is the Republican Party, except for the 2 senators from Maine. And we know how vicious, devious, how these people lie, and all that kind of stuff. And I just want to know how you think about that. I know you can't do anything about it, and I know you'd like to, but you don't talk about it. I'm a little hard of hearing, so I may have missed some words about this subject. But you don't talk about it, and as I say, you're powerless against it to fight these people. But how do you think about them?
Well, I would say that healthcare for all is rabidly nonpartisan. And that being said, that it is vitally important that all of us reach out to friends and family and make them do it. I think we have not demanded that our healthcare system be reformed. I think we have not demanded that it was time to cover everyone. And I think the time's come. I think we are as close as we've ever been. I think we have this opportunity that we can't let pass us by again. So I think it's up to us. I think we are required to get involved and tell folks that it's a simple phone call. Pass health reform or I won't vote for you.
Do you have any thoughts from the inside?
Well, I guess what I would, if I could face some of the Republicans, I would want to ask them just on a personal level what it means to oppose this. And who would you want for your mother's doctor? Who would you want for your doctor? And perhaps the percentage of Congress should do without health insurance, comparable to the percentage of Americans who do without health insurance. To anyone who works in medicine, or to anyone, I think, who's a sentient being, it seems that healthcare should be a right, not a privilege that we pay for. And how come we are happy to have police care for all, fire protection for all, roads for all, but not health care for all? I don't understand that as someone who practices medicine. To give me an explanation why that wouldn't be the same case for our health care.
Okay. I do want to ask one last question. That was a rousing end, so I hate to bring it down. But I do want to go back to these extra layers of bureaucracy that have been brought up. It seems, from my outsider in position, that a lot of the national debate has changed from health care reforming the system of health care delivery, to health insurance reform. And that is actually a phrase that I've heard repeated in the media and repeated by legislators. We're not reforming the healthcare system anymore. We're talking about reforming health insurance and giving people access not to a doctor, but to an insurance policy. And it sounds like that insurance policy can be the source of a lot of cost, a lot of layers of bureaucracy, a lot of time wasted. Is this really the best way to go about it, or is it only the expedient way to go about it? Do we have to reform insurance and then move on to reforming the healthcare system, or is it possible to skip that step and move on to actually giving people access to care?
My gosh, I think that health insurance reform is part of health reform. I think they're inextricably linked. And I think the examples that I talked about in Massachusetts, our experience here showed that providing folks coverage up front made a tremendous amount of difference. And now we truly are talking about delivery reform. We truly are talking about making sure that patients have as much time with Dr. Ofri as is needed to be able to talk about the ancillary issues and the presenting problem that takes you into her office. I think they are complementary and absolutely have to be approached together.
What do you think?
I probably have to agree. It's hard to imagine how we're going to undo our health insurance system. But I spent a little time working in an HMO-based practice, and my desk simply had probably 15 piles of forms from each HMO. And for one doctor, it required 3 administrators to work with me just to do all the paperwork, because every healthcare company had different requirements. And I was wondering, couldn't there just be one form for all the companies at least, so we don't have to have 3 secretaries to support one doctor? So I think it's going to have to be both.
Okay, that the idealist view is too ideal. Does anybody else have a last question? If not, going once, going twice, stand up.
I'm just curious, and that is this universal health care bill. It's I think it's like 2,000 pages or something. And I'm just wondering, is there anything about it which is sort of potentially threatening to the Massachusetts system? Or is it really impossible to tell simply because of the weight of the bill? You know, like these things often contain little time bombs.
I think, first of all, I would invite people not to be overwhelmed by the length. It is a big bill, and it makes sweeping changes, and it's worth a read. It's actually readable. And there are also some wonderful summaries available around online. So you can go to Healthcare for All's website. You can also go to our sister organization, Community Catalyst, which works on national reform in 44 states around the country, like Massachusetts. I think the most important thing for us right now is to know that if we don't pass national health reform, we will spend the next, name the amount of time, but at least 3 years, playing defense trying to maintain the gains we've made in Massachusetts. I think if we don't pass national reform, the next thing to go will be the work that we've done here in Massachusetts, because there'll be a perception that we don't have to have it. So I urge all of you to think about your investment in having comprehensive national reform and to get involved. It simply will not happen unless we demand that it happen.
So if it doesn't pass at the national level, that's what's threatening to Massachusetts.
I think if we don't take advantage of this opportunity, I don't believe it comes again in a lifetime. And for those of us who are residents of Massachusetts, I think we spend an awful lot of time playing defense and trying to maintain the gains that we've made, rather than what I'm asking for is the opportunity to do phase 2 of health reform, which truly is improving the delivery system and the experience that patients have with their providers. We have that opportunity here in the Commonwealth, and I believe we would lose out if we don't have national reform upon which to build it.
There's actually another threat. There was an article in the paper just the other day that a number of other states are actually organizing against compulsory health insurance. So there are many states that don't want a system like Massachusetts. I mean, there's a whole number of reasons for. But that in itself is threatening.
People don't fully understand what we've done here. I think we've had some misstatements about what it's cost the Commonwealth. I think there have been some misperceptions about the gains that we've made. So certainly part of Healthcare for All's mission is talking about the facts of health reform in the state. And imagine if you were living in one of those states to have leadership talking about not only getting on board to reform the healthcare system, but frankly not caring about the fact that you are living without access to the system, I think is wrong.
Okay, thanks.
Okay. Thank you, Danielle Ofri, and thank you, Amy Whitcomb-Slemmer. This has been an encouraging conversation by and large, and I look forward to reading the whole book. And there are on the back table some examples of the Bellevue Literary Review. So when your nose isn't to the grindstone, you actually you write yourself, but you are also the editor of this journal. What do you get out of writing?
Just briefly, working in medicine is very minute-to-minute, second-to-second experience with very little time for reflection. Writing is such a slow process by comparison, so I think it's the time to think about what we do and not just do it. Editing the literary journal is another way to put more of a creative spin, reading poetry, fiction, and nonfiction, that again also think about the experience of medicine, illness, health, disease, without just crunching numbers. So it's hard to imagine being at Bellevue every day. I'd probably end up in Bellevue, so I need to have this other part of my life.
Okay, thank you, Danielle Ofri. And again, thank you, Amy Whitcomb-Slemmer.